This week on the BackTable podcast.
You're going to have to study this in a trial, right? You can't just, Altan and I can't just start doing this in colorectal cancer. That's not going to work that way. You know, we would have to do this on a trial. How do you design that trial? Let's say in colorectal cancer, when they have good first or even second line options, they have now genetic subtypes and so on. So it's not as easy to design these trials in the other malignancies. Breast cancer is another one, but that one's even harder because you have now 15 different lines of systemic therapy. Where do you put this, right? And you're going to, if you even get oncologists, forget about us, you get 5 medical oncologists in breast cancer, where would you insert this? And even in a trial, you'll get 5 different answers.
First, a brief word from our sponsors.
RADPAD was developed by physicians for physicians. Clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RADPAD radiation protection shields for all your fluoro-guided interventions. See radpad.com for more information and contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap. And don't forget to tell them that you heard about it on the BackTable podcast. Now, back to the episode.
Welcome to BackTable. We have 2 phenomenal guests today. Sid Padia, interventional radiologist at UCLA, and Altan Ahmed, interventional radiologist at Moffitt Cancer Center. And we're going to talk about HEPZATO today. So welcome to both my guests, both leaders in the interventional oncology space in the U.S. Thank you for being here.
Thank you for having us.
Thanks, Kavi.
All right, so let's get started. We're going to, like I said, talk about HEPZATO, or ChemoSat as it's called in Europe. So tell me, Sid, what is HEPZATO? What is ChemoSat?
So HEPZATO, ChemoSat, kind of the generic name is PHP, or percutaneous hepatic perfusion. I would consider relatively new in the U.S. just because it got FDA approval last year, and is a device-related treatment for patients with liver metastases from uveal melanoma. It is a way to deliver high dose of chemotherapy into the liver. In this case, the chemotherapy drug is called melphalan, which is a DNA alkylating agent. And the device is designed for us to deliver this via the hepatic artery, just like we do many other hepatic artery procedures. But the difference is that we are withdrawing the drug at the same time via the IVC, filtering the drug out through a filtration circuit, and then returning the filtered blood back in. And so this whole device, including the drug, is called, the trade name is HEPZATO Kit in the US, which was FDA approved in 2023 for uveal melanoma metastases, and then became commercially available in 2024.
Got it. And so, it sounds probably to the average practitioner in the US, it sounds a little bit like a surgical hepatic pump, right? But this is obviously very different. So how is it different?
So I think there's a couple of differences. Number one, when we talk about infusion pumps in surgery, which actually our group does a good number of them in the colorectal cancer setting, the difference is that the drug that we're using in this case, which is melphalan, is very cytotoxic, potentially, and especially in terms of bone marrow suppression. So the systemic dose needs to be minimized. And so the difference between a surgically implanted pump and this is, the main difference is that we are withdrawing the drug after the first pass through the liver and then filtering the drug out through this filtration circuit. So that's number one. Number two, this is given all at once during a procedure. And then what allows us to do this in IR appropriately is that we're able to repeat this down the line, because this is all percutaneous. And by percutaneous, meaning femoral artery, femoral vein access, things that IRs are very used to and very comfortable with for the last several decades. So this allows us to repeat treatments for patients, which in the past, when this same procedure was done in the surgical setting, you really can't do this operatively multiple times.
Got it. So no implanted device, right? And then multiple procedures, like you said. So big difference, and kind of lends itself to our skill set, which is great. Altan, Moffitt has the longest running U.S. experience for PHP or HEPZATO, right? So we already talked a little bit about when it was FDA approved, but how long has the device been around? How long have you been using it at Moffitt to treat patients?
Great question. So yes, we have about over a decade now of experience with percutaneous hepatic perfusion. Device itself, in one form or another, has been around since early 90s, actually. First described in Japan and kind of at MD Anderson around the same time, early 90s, in animal models, and then 93, 94 is where the first human trials were conducted. So in some form, the double balloon catheter for hepatic venous isolation has been around and kind of evolved over time. Not only the catheter itself, but also the filtration mechanisms with the carbon-based system. So really an evolution of a technology that's been around for quite some time. And then even before that, if you look at isolated hepatic perfusion that Sid had kind of mentioned there, that has been described as far back as 1960. So an evolution of that, a surgical procedure that could only be performed once, great response rates, high morbidity. This is kind of a natural evolution and something that can be repeated and continue to be efficacious for patients.
Got it. And so over that time, I mean, obviously, like all interventions, right? We evolve, our patient selection gets better. So tell me, how are you choosing your patients, right? ECOG, Child-Pugh, ALBI scores. Give me some details.
So overall, not very different from most of our other local regional therapies. Liver dominant disease, number one, from a tumor perspective. Ideally, less than 50% of the liver being involved. ECOG 0 to 1. We don't want major cirrhosis, so Child-Pugh A, B, and C would usually be excluded. Baseline hepatic synthetic dysfunction would usually be an exclusion criteria for patients. Patients who cannot undergo general anesthesia. This is going to be one key difference from our other local regional therapies. This is a pretty intensive procedure for a patient. General anesthesia, perfusion, bypass, all that. So they have to be relatively healthy otherwise.
And cardiac strain, right? I mean, I think patients that have underlying cardiac morbidities, the blood pressure lability is there as well, right? What about things like, you mentioned tumor burden. What about biliary incompetence, post-Whipple, biliary stents, things like that? Those are areas where I will sway away from TACE and ablation, even with long-term antibiotics. And then Sid and I recently had this conversation about radiation segmentectomy and this type of patient as well. How about that patient population here?
I mean, fortunately, it doesn't really happen that often, right? So most of these patients, keep in mind, we're talking about a very targeted group of people who have liver metastases from melanoma. These patients, in general, are not going to have prior biliary surgery. If they did, it's most likely going to be unrelated to their cancer and perhaps related to something else. So we haven't really encountered that. The trials, which we'll talk about later, did exclude those patients just because you want to optimize your safety during a trial. We don't really know what's going to happen the first time we have that scenario. I suspect it's going to be fine because we're not causing tissue necrosis. So the challenge in doing radiation segmentectomy or thermal ablation or chemoembolization in the setting of prior biliary surgery is that you're leaving necrotic tissue behind. When there's reflux of contents in the bile system, you're going to get that necrotic tissue infected. This doesn't cause any necrosis. So I suspect we would probably put them on antibiotics, but I suspect it's not going to be a big issue, but we haven't had any experience with it. Altan, have you guys done any patients with biliary surgery?
No, like you mentioned, it would be a really infrequent situation for this specific patient population, but we haven't had that situation come up thus far, at least.
There's definitely two differences between this population and other patients with liver metastases, like, for example, colorectal cancer. Number one, these patients 99% of them have not received cytotoxic chemotherapy in the past. Many of them have received immune checkpoint inhibitors, which is standard of care, but cytotoxic chemotherapy is not. So the nice thing is that they shouldn't have the vascular effects from chemotherapy. They shouldn't have chemotherapy-induced steatohepatitis. Pretty much every patient I've seen has had absolutely normal hepatic function. And in fact, if you see someone who does not have normal hepatic function, something else is going on, which needs to be investigated. It's entirely possible they may have infiltrative tumor, which is going to cause liver failure. So the patients are pretty well set up for this procedure in that sense that I don't have to think about or deal with interactions with other chemo agents, at least at this time.
Great point. And for both of you, I guess, if you do see a patient that's on systemic therapy, what are you saying? Ipi-Nivo, tebentafusp, anything else?
We've seen, but those are probably the two most common. There's others, but we have not discontinued their systemic therapy during the course of this treatment. To our knowledge, we haven't had any interactions or adverse interactions between the immune checkpoint inhibitors and this. There are ongoing trials. One is in Europe called the Chopin trial, looking at the combination of immune checkpoint inhibitors and cutaneous hepatic perfusion, which is results will hopefully be out later in 2025.
Yeah, I think we're all excited to see that. I think the phase 1b data came out last year at ASCO, and they're hoping to publish the phase 2 data this year at ASCO. So that could be very impactful for this patient population. Altan, I want to go back to one thing real quick. Talked a little bit about cardiac comorbidities. Your group recently published troponin leaks after PHP, if I'm not mistaken. showing no long-term consequences and them all being subclinical. Again, obviously cardiac strain during the intervention, which we'll get to here shortly. But yeah, can you tell me a little bit more about that?
Sure. So, you'll often find troponin leaks in these patients if you're checking the labs afterwards. And we found that, overall, if there's no other sign other than the biochemical finding, that it's inconsequential for these patients. Echoes have not shown anything. So typically you will see a little bit of troponin leak just from the stress induced by the procedure itself. There's a lot of hemodynamic shifts, a lot of changes happening during the procedure. Not totally unexpected, but as long as you're, selecting patients appropriately, you wouldn't expect to have any adverse effects long term.
Altan, what pre-op stuff are you guys doing in terms of cardiovascular testing beforehand?
Typically just echoes, yeah.
Yeah, we were debating between just getting a resting echo and we decided to get a stress echo on everybody to, in theory, more simulate what they're going to undergo during a PHP. And so we've done that in every patient. It is not, I'll be honest, at least where I live, it's not easy to get a stress echo. There's a wait time and so on. So there are depending on where you are in the country or the world, there can be logistic hurdles in getting a stress echo. And, you can always have the occasional false positive as well that you're going to have to go down that rabbit hole. So it's by no means a perfect answer, but we've been doing that just in the interest of making sure that no one has an MI on the table, because that would obviously ruin our program in the beginning.
Absolutely. And for here, our practice has been resting for the most part, resting echo.
So let's get into that a little bit. Sid, if you can walk us through your workflow. We talked a little bit about the devices already that we're kind of using. We talked a little bit about the drug, but walk us through the workflow, the day of, the procedure, a little bit of pre-post, and what goes into the actual intervention.
So beforehand, it's similar to other patients who undergo local regional therapy in that we do a consultation in advance, insurance pre-authorization. To be honest, the insurance pre-authorization has been fairly straightforward so far. And the only real difference is that they undergo some kind of cardiac testing. In our case, a stress echo, but as Altan mentioned, in his case, a resting echo. So that's the real one difference. And we also have an anesthesia consultation, which is typically done virtual. So those are the two changes.
Real quick, are you getting an MR of the brain or a CT of the brain beforehand to look for intracranial mets?
We've debated, and the reason to get an MR of the brain is to look for intracranial metastases. You do pretty heavy doses of anticoagulation during the procedure. We have not yet started routinely getting MRI brains. Part of it is a logistical issue. We have quite a bit of delay in getting outpatient MRs, so I try not to push the patients back too far. I don't think it's a bad idea. That being said, the incidence of brain metastases from uveal melanoma is pretty low. That being said, it's not zero. So I think it's, at this point, probably operator choice whether to get one. Altan, are you guys getting brain MRIs in everybody?
We are, yeah.
In terms of the day of the procedure in the morning, it's pretty much the same as anyone else getting any local regional therapy. Once we put them under general anesthesia, the main difference is we do get a Foley catheter. They're getting a radial arterial line, and we put in a standard triple lumen central venous catheter, and that's really for blood draws during the procedure and to give intravenous vasopressors.
Got it. And so you mentioned earlier, arterial access, venous access. Arterial access is standard 5/6 French. Venous access is how big? And what is that? What do you put through that venous access?
Yeah, so it's interesting. Altan had talked about the fact that Moffitt's been doing this for over 10 years. I think what's evolved over 10 years and what now really belongs in the IR alleys, over the last 10 years, two big things have happened in our profession. Number one, we started working with anesthesia more and more often. I think when I started practice in 2009, getting an anesthesiologist in the IR suite took a lot of effort. Nowadays, they're there all the time, so they're comfortable with it. Number two is working with large bore devices, specifically in the venous space. Now that we're doing so much DVT and PE work, putting in a 24 French sheath in the right femoral vein, where I thought would have been 10 years ago would have been insane, is now fairly common in our practice. So when we talk about the access sites, we're really talking about a 5 or 6 French femoral arterial sheath, that's standard, that we do 5 times a day, an 18 French femoral venous sheath, and a 10 French right internal jugular sheath. So these are all pretty standard and routine accesses that all IRs are proficient at performing. And in terms of the catheterization, it's relatively straightforward. So I think from a technical perspective, if you, for example, can do chemoembolization or radioembolization, this is really nothing that you can't do.
Absolutely. Well, and I would argue, both of you, please feel free to disagree with me. On the arterial side, it's a base catheter, it's a microcatheter. You're parking usually right, left, relatively lobar type distribution. So it's not a lot of complex arterial catheterization and then infusing from there. On the venous side, it's that double balloon catheter, right? So the top balloon is at the caveatrial junction, bottom balloon is below the accessory hepatic veins, and you're literally isolating the liver as a circuit, which is one of the things that's most fascinating about this intervention to me. But yeah, tell me more.
I mean, we've been doing lobar treatments, and by lobar, I mean right hepatic artery, middle, left, et cetera, in every patient, and then effectively treating the whole liver in every case. Altan, are you guys doing the same thing?
We are, absolutely. We're treating the whole liver.
Are you doing any segmental treatments? Because we have not been. It doesn't really make, for us at least, a whole lot of logical sense to start doing, PHP segmentectomies and so on.
No, we're not there yet. We're also in the lobar space.
Yeah, so as Kavi, as you said, the catheterization itself, let's say compared to an average Y90, is probably going to be on average either the same or a little bit easier.
And so we're isolating the liver with that double balloon catheter, right? 2 large bore or large balloons on an 18 French catheter. And then Altan, you mentioned the veno-veno bypass circuit already with the filtration. Tell me a little bit more about that and how that works.
Sure, absolutely. So as you mentioned, there's a catheter itself has a cephalad balloon, cranial or an caudal balloon. The cranial balloon is wedged at the inferior caveatrial junction until it kind of, it's inflated and then retracted until it seems kind of like an acorn type shape and wedged into that junction. The inferior balloon is inflated until it kind of flattens around the edge of the IVC. To confirm that we have isolated that segment, we actually take the patients off pump momentarily and do a venogram to make sure we have stasis of contrast within those 2 balloons and no leak, most importantly, a cranial leak that would go into the right atrium. Once we do that, the patient is basically brought online for the filters, the charcoal filters sequentially, which are arranged in parallel. We put those in, and then ultimately, once the hemodynamics have stabilized, you clamp the bypass line. I should say that, when we put the balloon catheter in, before we inflate, the patient is put on the pump and the circuit is started before any of that happens.
Got it. Okay. And so obviously, as we mentioned already, there's a lot of cardiac and blood pressure lability here during the intervention. What are the points? I mean, you have an anesthesiology team in the room, you have a perfusion team in the room, and that's the IR team, right? So what are the or IR or, plus surgical oncology, or every center I think is a little bit different, but what are the points where you're really kind of communicating about, well, the blood pressure is going to change here, we need to be on the same page? What are those points during the intervention?
So the one thing to keep in mind is that you have your anesthesiologists at any center are going to be trained, right? So they're going to go observe a patient getting treated at another site, and then they get proctored. So they're not walking into this new. Our anesthesiologist, I think, actually went to Altan's center at Moffitt and watched him, and our lead nurse and our lead tech also went there as well. So they learned from Altan's group. Our anesthesiologist learned from them. They brought it over, so then they kind of knew what to expect, and then they got proctored as well. So their first case, an anesthesiologist came in and watched them do it. So there is a little bit of prep, and we have right now 3 anesthesiologists who are signed off to do this. So it's not our entire, 150 anesthesia faculty group that does this, kind of the doc of the day. I personally think, there was always discussion, when this started, do you need a cardiovascular or cardiac anesthesiologist? I don't think we do. Even though that we're using a bypass circuit, there are certain key points where the blood pressure will drop. Number 1, when you inflate the balloons. Number 2, when you hook up to the filter. But as long as the anesthesiologist is prepared for it and you kind of work together, it's honestly nothing that they can't handle.
Yeah, great point. And going back to what you said earlier, right, all 3 teams not only have to go observe a case, but then have to be proctored for their first case. I think that's an FDA mandate. So that's anesthesia, that's perfusion, and then the interventional team, whether that's IR alone or IR plus surgical oncology, depending on what center you're at. So, okay, so that's a great point as well. So a couple of key points during the intervention where the blood pressure will drop. Anesthesia's on alert to kind of push the blood pressure with some pressors, right? Kind of learned that over time, that flooding with a lot of fluids just kind of overloads the patient afterwards as well. So optimizing the blood pressure, preventing kind of vasospasm so we can deliver the drug. How long does this all take? This is a long process, right? So how long does this all take?
Are you asking about our first patient or the most recent patient? Because there's definitely a learning curve.
Absolutely, right? I mean, that's a great point. So your first case, and Altan, it's been several years for you, but if you remember, how long was the first case and where are you now?
That's a good question. So overall, I would say on average, you could anticipate about 3 to 4 hours. Now, your first cases might be closer to 5 hours, just depending on logistics. There's a lot of different teams involved here. As you mentioned, each center is going to be a little bit different. At Moffitt, we do work hand in hand with our surgical oncology colleagues. So it's actually a surgical oncologist an interventional radiologist, the perfusion team, anesthesia, and then pharmacy. That's another big key that we have there. You have to be in very close communication with the pharmacy. We are actually requesting the drug to be reconstituted at a specific time so that we are not wasting time and it doesn't start to degrade. So, all of these things add to the time needed for the procedure. And if, by chance you happen to order the drug sooner than you are ready and end up waiting too long, you may have to get more drug later on, which can extend the time for your procedure.
Yeah, I would say that our first procedure took about 3.5 to 4 hours. Now, our last several, and I'm talking about the IR procedure time, not including the anesthesia setup time and anesthesia breakdown time, is about 2.5.
Wow.
So it is actually quite manageable. And part of it, as Altan mentioned, is coordinating with pharmacy. So the way it works is that the drug comes in a powder. It cannot be prepared, the night before or so on, because once it is prepped by the pharmacy, meaning made into a solution, it has an expiration. And that expiration, I think, is around 60 minutes. And so you need to really get it into the patient within that 60-minute window. So that includes, them delivering to the IR suite, hooking it up, et cetera. And then, for example, if you're going right, middle, and left hepatic arteries, you got to do all 3 hepatic arteries within that 60 minutes. And so you can't just have the drug sitting in the room and then start your procedure. So you want to time it appropriately. And at the same time, you don't want to ask for the drug at the very last minute and then sitting around for 30 minutes while they're mixing the drug and the patient is on these filters, relatively hypotensive, or at least on high dose vasopressors at the same time. So a large part of this learning curve was trying to time everybody in order to minimize your downtime and to minimize any degradation time of your drug. And so we kind of figured out a pattern where it worked well for us. And lately, I would say our procedure time, the IR procedure time, is about 2 hours, 30 minutes.
That's fantastic. I mean, for me, that's a complicated 3-4 dose Y90 delivery, trying to move my catheters around in different places, right? In a patient that can't get sedation. So that's pretty amazing. What about you, Altan? Where are you at today?
Around the same thing, 2.5 hours for the IR time. Obviously, getting the patient back there adds total room time closer to 4 hours. But, as Sid mentioned, I think it's a really important point. Your balance is minimizing the pump time and maximizing the amount of time you have for the drug to be most active.
Great point, right? And you're, as you said, 60-minute time for, before drug expiration, right? You have to get the drug in. You're having anesthesia monitoring the blood pressure and optimizing the blood pressure, so you're not getting a lot of vasospasm, so you're not getting reflux of the drug. At the same time, Altan, you alluded to it, there's some data out of Europe that the longer you're on filter without delivering the drug, there is some degradation of the filter and you're extracting less drug, right? So important to time going on filtration at the right time and then immediately start giving the drug, correct?
Absolutely. So, the filters lose efficiency over time. So the longer you're pushing blood through it, the less efficient you're getting at extracting that drug and the more possible systemic exposure you're going to have to deal with on the tail end of this procedure. The other part of this is, just pump time in general also is associated with increased morbidity after the procedure as well, like the thrombotic events and whatnot.
And these things all take practice, right? In the beginning, the coordination's not perfect. One of the things I've noticed in not only in our center and other centers, when you're starting out, you don't know how long your pharmacy is going to take, right? Because beforehand, when you have your meetings with them, they're going to say, okay, it's going to take 20 minutes. And then in reality, it's not 20 minutes. And you find out, your pharmacy is not a 3-minute walk. It's really an 8-minute walk, right? But then after a little bit of practice, you're like, okay, now I know that as soon as I get my reverse curve catheter in the celiac artery, I can call for pharmacy because I know that's how long it's going to take for me to get catheterization of all the hepatic arteries and put the double balloon catheter up and hook up to the filter. It'll take me about 20 to 25 minutes to do all that work. And so now I can kind of time it appropriately.
Exactly. And each practice is going to be identify those little time points that fit for them based on, pharmacy location, pharmacy time, turnaround time, and all that kind of stuff.
I mean, one of the interesting, from just a practice standpoint, not a medical standpoint, of having done, all of us have done a lot of oncology practice and we have a huge venous practice. One of the differences of this procedure compared to others is the amount of coordination you have to do. It's not the technical challenge. And the amount of coordination you have to do has been both highly challenging and highly gratifying. You work with groups that you're not used to working with, like groups like perfusion and specific anesthesiologists. So it's nice you develop relationships with these people. We've developed, a great deal of cohesion. We figured out ways to just kind of improve our practice in general. So there's been, kind of a lot of positives that have come out of starting this practice.
And just the patient population, right? I mean, this is a rare tumor patient population. They don't have a lot of options. This is a pretty amazing interventional solution that we can now offer them, right? And so I think that's also super gratifying on our end as well, right? That we can offer this to the patients.
Yeah, it's interesting. These patients are very different than other people with hepatic metastases for several reasons. Number one, when you look at their prognosis, even with the standard currently available systemic therapies, it's pretty poor. Tebentafusp, which is one of the immune checkpoint inhibitors, but it's really only valid for about 40% of patients with a specific HLA subtype, is quite effective. But, once they fail that, there's not really a great second line. And if you're not a candidate for tebentafusp, you're talking about the standard nivolumab and ipilimumab, also relatively low response rates and not a great deal of survival. So there's other trials of other systemic agents, obviously in the pipeline, but overall, this is not let's say, if you compare it to breast cancer, which there are, 20 different lines of systemic therapy that I think most IRs, it's way beyond our real deep understanding. This is relatively wide open. There's not a lot of options for patients. So it's nice that this came out where this has the potential to treat a very heavily needed patient population. And it does not have, as far as we can tell, any adverse interaction with the currently available therapies. I think the one difference from a practice standpoint, uveal melanoma, we're not talking about cutaneous melanoma, uveal melanoma is relatively uncommon. So if you're thinking about starting this in your own hospital, you really have to look at, do I have this patient population? Am I going to be seeing one patient a year? Because if you are, it's really not worth the effort to start a program like this. Both Altan and I happen to work at places which have a big uveal melanoma population because we have either surgeons or medical oncologists or ophthalmologists who really focus and specialize in this. And so, for example, in our case, we have people drawn from pretty much the entire West Coast who see our one ophthalmologist, Tara McCannell, and that's all she does is uveal melanoma. And so because of that, we have this pipeline of patients that get funneled into UCLA from pretty much the entire Pacific time zone.
That's and I suspect that that's probably happening across the country, right? Like regional referral centers for uveal melanoma, as you already alluded to, whether it's Jefferson in Philadelphia, Altan and Moffitt. We're starting a program in the South I'm at University of Alabama, Birmingham. And so you have these kind of pockets of patients and they can kind of go. And then, as you already alluded to, there is an experience standpoint portion to this, right? And we've learned that from every other intervention. So the more experience these individual centers have, the better off their patients do, correct?
Yeah, I mean, it's never going to be like the way thermal ablation or radioembolization or chemoembolization is practiced now in the United States, where I live in West Los Angeles. If I were to, make a 10-mile radius from my hospital, there's probably 8 or 9 other centers that do radioembolization. That's not going to happen with this therapy. Even in Los Angeles County of 10 million people, there's probably at the end of the day maybe going to be 2, maybe 3, but probably 2 centers that perform HEPZATO for this population. For Altan, I can't imagine there's going to be another center in Tampa that's going to be doing HEPZATO.
Highly unlikely. As you said, it's going to be set up more as a regional referral type practice, which I think it's great. You want to have expertise in what you're doing and offering these patients.
And keep in mind, but that also means that it doesn't necessarily have to be in this ivory tower quaternary care center either. There are other places they're private practice places. Honor Health in Arizona, a private practice hospital that's doing very high quality work that is doing HEPZATO procedures. So it doesn't necessarily have to be, you need to be in these ivory tower academic centers. I don't personally think that's the requirement. I think the biggest requirement is that you have to have the patient population to treat.
I agree.
That's a great point. And Sid, going back to what you mentioned about thermal ablation and Y90, I think that's a great segue. So Altan, the drug dosing is part of this as well, right? And in the FOCUS trial, which is a landmark trial that got HEPZATO FDA approval, it was just a flat dose above a certain body weight, right? Tell me a little bit more about the drug dosing. Do you ever dose reduce in certain situations in these patients? And I know that's a little bit of a loaded question because we don't know the answer to that probably at this point. And then is there going to be a role in the future to, as opposed to just dividing the dose between right and left liver, dosing to tumor burden, something as we do with Y90?
All great and very important questions. So yes, there is a dose that kind of came out of the phase 1 trial out of the NIH back in 2005, and that dose was 3 milligrams per kilogram for ideal body weight. They tested anywhere from 2 to 3.5, and 3.5 is where they had the most adverse events. So 3 was selected as the dose to a maximum of 220 milligrams. So ideal body weight is the key thing here. Now, when we do dose reduce, there are instances where that is done, typically in patients who have adverse events, mainly neutropenia. So delayed recovery in between treatments, or they have, neutropenia leading to an infection or something like that, or febrile neutropenia. So if they have delayed recovery over 6 to 8 weeks for their white counts to bounce back or recover, then we would consider that patient for a 2.5 milligram per kilogram dose versus the standard 3. And Sid, I'd like to definitely hear what your practice has been so far.
So thanks for the recommendation on that. I appreciate it, because I think that the dosing is, right now, in my opinion, the dosing is terrible, to be honest, but that also means it leaves a lot of room for improvement and optimization. So, as Altan mentioned, it's 3 milligrams per kilogram and kilogram is measured in ideal body weight. And when you look at the specific instructions for ideal body weight, it makes no logical sense on how they came up with this equation for this specific drug. It's really based on the patient's height and sex, whether they're male or female. So, in other words, in my inexperienced opinion, and not having done several hundred of these, the dosing seems very antiquated. It reminds me of back 15 years ago when we were using radioembolization and doing it based on BSA formulas. Having arbitrary cutoffs for lung shunt fraction. That's what it brings me back to. So the good thing is that the FOCUS trial used this dosing data and got their published results. So in theory, if we can try to optimize the dosing over the next 2 to 3 years, maybe we can even get better results. Can we optimize the dose based on the patient's tumor burden, based on liver volumes instead of body weight, and so on, and really figure out how to drop the dose in those cases of neutropenia, as Altan mentioned. Is 2.5 sufficient, or do we keep the same dose? Is it really dose dependent, and so on? So all these variables, I think we can optimize in the next 2 to 3 years, especially as more centers come online and we try to collaborate and share data, that hopefully the results will get even better than they are right now.
Yeah, definitely a big opportunity there, Kavi and Sid, as you mentioned, to start looking at tumor volumes and liver volumes and see if there is a better way to do this.
I mean, to me, it makes no sense if you have like 40% tumor burden versus 2% tumor burden. We're giving the same dose, right?
Absolutely, yeah.
That doesn't really sit well with, I think, most of us who do chemo and radioembolization, because that's not how we do those two procedures.
Right.
Great point. And we'll see. I mean, I think only time will tell as the intervention evolves, right? What about cycles of treatment, right? The FOCUS trial was 6 cycles of treatment or up to 6 cycles of treatment. Not everybody got all the way to 6. There's some patients that in Europe has had chemosat, which is what they call it, for over 10 years now. They've got up to, Altan, I don't know off the top of my head, 8 to 9 maybe cycles, something like that. Where do we kind of envision that going in the U.S.?
This is one place where I feel like there is going to be improvement, especially with Chopin and some of the combinatorial therapy trials coming out soon. Is it necessary to go all the way to 6 treatments, or can we get to like a steady state where we have response and patients are kind of stable? They either have, hopefully a complete response, but that's not going to be the most common finding. So they have a significant response. You do your combination therapies of PHP plus whatever else may be there. And then do you watch and wait for a little while, or do you just keep going until you have progression? And I don't know ultimately what the answer to that is going to be, but Kavi, I think, some of our discussions with our European colleagues has been that they've kind of started erring on the side of fewer treatments and watching and waiting. Sid, what has your practice been like so far?
Yeah, and it's funny because I think the three of us with some others had this email conversation several months ago about, when do you pull the trigger for the next treatment? Yeah. And I think we're all over the map, and I don't know if any of us are right, because I don't know if there's a right answer. We've been playing a more conservative approach similar to what you're saying. I'm not trying to get a complete response on everyone and just going, you're going to get 6 treatments up front. I see this more of a marathon and not a sprint. This is not curative in intent, just like most therapies for stage 4 cancer. And so the goal is to get longevity while preserving their quality of life, right? So to me, the best thing that makes sense is to stretch these out a little bit to try to get some objective response, but then maybe perhaps hold, right? Like we don't even necessarily go to 4 treatments if we're getting a response after 2. Is that the right answer? Only time is going to tell. It does remind me of our evolution in experience in treating patients with neuroendocrine tumors, which I know that, for example, the Moffitt group has a lot of experience with, where we would go, when we were starting out over a decade ago, going very aggressive, trying to hit every little thing, and finding out that you have no options 2 to 3 years down the road, or you cause liver fibrosis and so on. And so now what we do is a much more patient-paced, methodical treatment algorithm for these patients, where we're only picking off enlarging tumors or big tumors and so on. So we're not seeing hepatic fibrosis or bad vasculature anymore, and we're able to stretch these patients out for over 5 years, and sometimes now even approaching 10 years. And I think we can try to do the same thing with HEPZATO as well.
It's a great point, right? This is a non-embolic, non-liver toxic therapy, right? And so we're kind of walking the line a little bit, because even in the FOCUS trial, there was a significant portion of patients that required at least 2 treatments to show response. But at the same time, as you said, we're not going after a complete response. So just loading them on, loading the drug, loading intervention, and then having bone marrow toxicity down the line can be a problem as well. And so spacing those treatments out, as Altan alluded to, we don't know the right answer, and hopefully we'll figure it out over the next 3 to 5 years.
I mean, we still don't know, is this better? Is radioembolization better for uveal melanoma? There was one analysis published out of Europe looking at a propensity score match, retrospective of about 35 patients in each group, which suggested that percutaneous hepatic perfusion was superior. But again, it's really one study. So we're still trying to figure out our algorithm. I think one of the big advantages of this therapy of HEPZATO is that it is non-hepatotoxic. The rate of liver decompensation is extraordinarily low. In every single patient I've treated, we've measured their LFTs afterwards. Not even their AST or ALT will budge, even the next day. So it really does seem to be, pretty benign on the normal hepatocytes.
I think that's going to be a huge thing for the future. Sorry, Kavi.
No, go ahead.
But, I think the chronic liver toxicity is just not there. And ultimately, what this is going to mean is that we're not really burning bridges for the alternatives, whether it's tebentafusp or whatever may come down the line later. And this is huge for the patients. If we can preserve the liver, get control of the disease, we're just extending their lifespan here.
And we're even starting to integrate this with radioembolization. Someone might get a radioembolization, they may have a good response, they may progress in the future, and then can we switch to this, or vice versa, right? So it's nice to have this other tool that we can use for these patients that does not have overlapping adverse events, right? It's not the same adverse event profile. So in other words, you can kind of figure out how to mix and match these therapies. Of course, from a data perspective, it's going to be very hard to tease this out. It allows us to just offer more therapies that are kind of individualized and personalized for patients.
That's a great point, right? Do you treat the bulky disease with, a RADSEG type approach, and then come back and treat the rest of the liver, knowing that there's probably miliary disease elsewhere with PHP, right? It makes a lot of sense. We just don't know the answer to. But I want to back up real quick. Sid, tell me, how are you managing these patients post? What are the other risks that you've seen or adverse effects that you've seen so far?
Like everything, we took a very conservative approach in the beginning, and then we've liberalized it a little bit with time. So in the first 2 to 3 patients, we would always put them in the intensive care unit. We realized that was overkill. In our practice, we're using closure devices just like we use closure devices for our other procedures. And so we are now sending them to our standard PACU. We keep them overnight. And in actually some cases, we've been sending them home the same day after 4 to 6 hours. So our post-op is really, they get a platelet transfusion at the end of the procedure. We do measure their CBC at the end of the procedure to make sure that they're not thrombocytopenic or have a low hemoglobin. And we transfuse if necessary. We're typically discharging them within 24 hours of the procedure, either the same day if they're done in the morning, or we keep them overnight and send them home. And then we do a pretty close, I think the one thing that's different is we do a reasonably close follow-up with labs within the first week. The biggest thing you want to watch out for is a drop in your white count, which then needs to be at least addressed. And again, there's no huge consensus, but in terms of how to address it, one way is just observation and just follow it until it normalizes, or the other one is to give them a white cell stimulator, which is an injection. So those are kind of the 2 options. I work with our oncologists to figure out what is the best option. The oncologists that I work with, I would say, are a little bit different in their approach than I think most other oncologists. They are not big proponents of giving injections for white cell stimulators. So their preference has been to let that white count will always drop a little bit. Their preference has been to let it just kind of drift back up on its own. And I think that is in contrast to most other centers, which are probably more aggressive in addressing it pharmacologically.
Altan, how about you?
Yeah, I think that's a good point. I don't know what the right answer is for this, but our practice is typically, we'll admit them overnight to the ICU. We are not currently using closure devices here, but all our patients do get a white cell stimulator within 48 to 72 hours of the procedure, usually before discharge. So a little bit different in that, but close follow-up for laboratory findings, particularly the CBC. The nadir on the white count drop is typically within the 10 to 14 day time range. So, within the next week after the procedure and then weekly thereafter for about 4 to 5 weeks until the patient has stabilized and is rebounding.
Got it. And then, so that's a great point. So bone marrow recovery can take a little bit of time in your experience, generally in that 2 to 3 week time frame for both of you?
Interestingly, in our experience, after procedure number 1, it's been quick. After, let's say, procedure number 3 or 4, it's taken, for that same patient, it's taken longer for them to recover. Altan, have you guys seen the same pattern?
Yeah, similar here. Kind of, I guess the additive exposure to the melphalan has kind of delays the recovery a little bit.
And ironically, the overall tolerability of the procedure, surprisingly, even with all these accesses, cardiovascular effects, anesthesia, and so on, the patients return to pretty much normal after about 3 days. Like most of my patients are returning to work, even if it's a physical labor in terms of their jobs, within a few days, other than soreness at the access sites. It does seem like the physical recovery is faster with each successive procedure. So HEPZATO number 4, they seem to tolerate really well compared to the first one, which is kind of in direct contrast with the bone marrow recovery.
Very similar to what we've been seeing as well.
Got it. Okay. And going back to the quality of life issues, so really not a lot of quality of life issues. I know we have some quality of life data. I think the Southampton group, and then, correct me if I'm wrong, gentlemen, more recently the Leiden group as well, maybe, but showing, return to function fairly fast, as you both said.
Yeah, I would say that the biggest effect is the anesthesia. They're undergoing general anesthesia for a few hours, so you're going to have the effects of anesthesia. The other side effect is we do see some patients, not all, with nausea for, I don't know, maybe up to a week. So we're pretty aggressive with our anti-nausea regimen. We kind of really ramp that up. Scopolamine patches, Danzatron, Okay. Sometimes Compazine PRN. So we're very aggressive in that, and that has helped in terms of battling nausea. And I'll be honest, I don't even know if the nausea is from the procedure or from the anesthesia.
Got it. Okay. And then, I wonder sometimes, are some of these effects related to excessive melphalan exposure? And so let me lead you down this path. So you have a patient getting a first-time treatment, has severe bone marrow suppression. Do you think that's an individual patient issue, or maybe the balloon leaked a little bit more melphalan systemically than we thought, something like that? Altan, I don't know. What's been your experience?
Oftentimes, I think it's a patient-specific thing, and we start to look for answers. Anything specific anatomically in this patient? Is there anything we can identify in retrospect that we could change? But oftentimes, it's usually a patient-specific thing. Sid, what is your experience?
Have you ever found anything, Altan? We've looked at all our patients, and I don't know, but I can't. To me, it seems like dumb luck that it happens.
Yeah, pretty much. Yeah, when you go back and look at it, there was a publication a while back looking at the leak and doing some specialized imaging on the DSA to actually quantify the degree of leak at the cranial balloon. Ultimately, I don't know that any of those patients, their time course or the way they tolerate the procedure would have changed at all. It's not something that you would change on the fly, I don't think, in terms of dosing, at least.
Yeah, great points. Okay, I think that's very helpful. I mean, obviously unanswered questions. So that kind of brings me to the next question. What are the other? We've talked about some of the gaps in the current iteration of the intervention. So what are the additional gaps that are out there that we need to address with future research? Tell me, guys.
I think one of them is to stratify patients. Right now, we're kind of, for better or worse, let's say from a tumor perspective, we're taking all comers, right? We're, in other words, the requirement from a tumor perspective is to have multifocal bilobar disease. Now, does that mean you have 1% tumor burden, or does that mean you have 40% tumor burden? And, so if we can start better stratifying those patients, uveal melanoma looks different on every patient. So sometimes you have these T1 tiny little bright lesions. Sometimes they enhance like HCC with, arterial enhancement and washout. Does it respond better in those HCC type looking lesions, or does it respond better in these bright T1 type lesions? Because I'm starting to, and these are all anecdotes, but I'm starting to see different patterns of response based on what their baseline MRI looked like. So I think that if we can start to tease this out to figure out who it's working in and who it's not, we can start then saying we should be aggressive in terms of approaching patients or offering this to patients in where we think the success rates are going to be higher and so on.
That's a great point, Sid. There is obviously a spectrum within the uveal melanoma disease process itself. There's some who are more prone to developing metastases in the first place with certain genetic markers and whatnot. Does that also influence how they respond to these treatments? So that's going to be very interesting to see in the future, for sure. And I think another part of it is, optimizing dosing we had mentioned and touched on a little prior. And then, seeing, is there anything we can change in terms of filtration in the future? Is there going to be a better generation of filtration? Can we extract more of this melphalan to minimize the systemic side effects? And then looking at other histologies as well. I think that's the next natural step here as well.
Yeah, that's, and we've gone down this path for other interventions, right? And so, Sid, you alluded to it earlier. In the early 190 days, we treated with BSA, then we kind of moved to MERD, and now we've moved to partition, and we have threshold dosing for a lot of our tumors. So I kind of envision that in this space as well. Again, better patient selection, better filtration, and then hopefully stratifying, which patients are going to have optimal outcomes versus less optimal outcomes. And maybe we still offer the intervention in that kind of intermediate category of, some benefit, but not, great benefit, especially if there's nothing else to offer, right? But helpful to know, helpful to educate the patient as to what to expect, right?
Absolutely.
So we've talked a little bit about already where this fits into the current algorithm of uveal melanoma. I personally have moved away from radioembolization, especially for miliary disease, not just for melanoma, for everything, just unless it's a very hypervascular lesion and I have a great TNR. How do you both feel about Y90 for miliary disease in this disease type?
So, it's a great question. If you look at I actually think the Y90 data for uveal melanoma is quite good. The best paper comes out of Karen Gonzalez out of Thomas Jefferson, where she did a phase 2 prospective study. Her response rates were very good. They're actually in the kind of the same league as HEPZATO in the around 30% objective response rates based on RECIST. So it's unfortunate that it's not FDA indicated or FDA approved for this specific indication, which does kind of handcuff us a little bit. The miliary disease, if you have a patient with a bunch of little dots throughout the liver, if you actually measure their overall tumor burden, it's still relatively low, right? It's going to be 10% or maybe even less. And so what happens is when you're doing a radioembolization, you have to treat the whole liver. You're going to get almost impossible to quantify it, but you're going to get a good amount of normal hepatocyte radiation deposition. And so those are the patients I try to shy away from, not because it's not going to have any tumor response, but those are the patients that you will see higher incidence of liver-related adverse events, in contrast to a single 6-centimeter hypervascular tumor, which is the exact opposite. So those patients with 20, 30, 40 tiny little dots scattered throughout the liver, I think HEPZATO is a great option because it is non-hepatotoxic.
And it's been the same in our practice as well, moving away from Y90 for the miliary type pattern of disease, and something, HEPZATO has not had those chronic liver effects that we mentioned earlier. And then localized disease, definitely Y90. If you can get there to a segmentectomy, that's fantastic.
Yeah, and I've seen a lot of patients with, I hear this argument that if you see, one big tumor, 1 5-centimeter tumor from uveal melanoma in the liver, that means it's all over the liver. I don't believe that at all. I've had lots of patients where I've treated that 1 5-centimeter tumor and they've had prolonged response for even on the order of years. So, I'm happy to show examples to other people that's not necessarily the case, that if there's smoke, there's fire. I don't think that's necessarily true all the time. So you have someone with 1 or 2 or even 3 tumors that are solid, that are well circumscribed, that are focal, that you can target selectively. Radioembolization, to me, is my go-to therapy in those cases.
Yeah, that's a great point. The other thing I'll add to that, and we kind of know this from other disease types as well, that preoperative MR or CT can sometimes be a little bit misleading, right? You get a catheter into place, you do a cone beam during the intervention, and you may see other spots light up, and that may change your treatment algorithm a little bit. But to your point, right, I totally agree with you. If you just have isolated bulky disease, then I think you both mentioned it. Radiation segmentectomy type approach is totally relevant.
Altan, what pre-op imaging are you getting prior to your cases?
Typically MRs.
With a specific type of contrast or just anything?
Anything. It's usually not any of this. We just use the standard guide.
Because we've been using UVist MRs for these patients, and we found that we're picking up a lot more tumor than, let's say, a CT, which is night and day.
On the delayed phase?
Yeah.
Okay. All right.
So if you look at that 18 to 19 to 20 minute UVist MR, you end up seeing a lot more tumor than you really thought there was going to be.
That's a great point. And so then maybe a little more apples to apples to the arteriography and cone beam CT.
And I think that even though these limits of 50% tumor burden and so on, when you deal with PHP or even any other local regional therapy, especially melanoma, if you see 50% on a CT with IV contrast and you do that MR with UVist, it'll be 99%.
Yeah,
it'll be completely replaced with tumor, right? So I think that's where people are saying, oh, you're getting adverse events if you have 60% tumor burden. In reality, you don't have 60% tumor burden. In reality, you have 99% tumor burden, and the patient's dying of liver failure from tumor infiltration.
Great point. All right, so I want to end on one last question, and I fully recognize that this is kind of reaching into the future a little bit, but where else can this therapy be applied? What other tumor types? You guys, you both know this question was going to come. So, what other tumor types can we utilize here? Where are the other gaps in our IR armamentarium that we really don't have something to offer that PHP in its current iteration or a future iteration can kind of fill those gaps? Sid, why don't you start?
Good question. I think right now it's going to be still isolated to liver, just the way that the kit is designed. So in terms of other organs, let's just assume we're talking about liver. And so then we want to talk about
metastatic disease in the liver.
Yeah, unmet need, right? So the unmet need, I think, is the biggest one is colorectal cancer. That's probably number one on the list. It's probably, none of them are going to be easy to study. That's one of the challenges because you have so many different lines of systemic therapy. Where do you, let's say you're going to have to study this in a trial, right? You can't just, Altan and I can't just start doing this in colorectal cancer. That's not going to work that way. We would have to do this on a trial. And, how do you design that trial, let's say in colorectal cancer, when they have good first or even second line options, they have now genetic subtypes and so on. So it's not as easy to design these trials in the other malignancies. Breast cancer is another one, but that one's even harder because you have now 15 different lines of systemic therapy. Where do you put this, right? And if you even get oncologists, forget about us, you get 5 medical oncologists in breast cancer, where would you insert this? And even in a trial, you'll get 5 different answers.
A very loaded question for sure, but I think I'd agree with Sid. I think colorectal is the next natural kind of histology to look at. It's not going to be easy because where do you insert this therapy, right? First and second line are great. Second or third line, I think, is an opportunity there. There is a pretty sharp drop-off in systemic therapies from second to third line, the efficacy of those therapies. So, that's kind of where we would get some referrals for Y90 and whatnot. Maybe we can insert PHP there and see how these patients do. And honestly, I think the biggest deal is going to be that we're not seeing that chronic liver disease. A lot of these chemotherapies are very, very hard on the liver. You guys can think back to all the referrals you get for breast, colorectal, whatever it may be. But, these patients, their livers take a pretty big hit from these chemotherapy. So, there is an opportunity there. Where it's going to fit in exactly is still a question mark, and I don't see it happening outside of a trial setting. It's just going to be very challenging to generate high-quality data without that.
There are some case series and very small series out of Europe. I think the challenge is they're challenged by numbers as well, right? So they had like 7 or 8 patients. It's very hard to make conclusions from 7, 8 patients.
One really promising thing, really, I'll just add on to that a little bit is, the IHP data from the surgical procedure has shown pretty significant response rates for colorectal already in the 50-60% range. So there is a precedent to kind of use this methodology there as well.
Well, and I think to both of your points, there are also 2 separate patient populations with colorectal, with any metastatic disease. You have the oligometastatic population where you can kind of pick off individual lesions either with RadSeg or thermal ablation or both or whatever. And then you have the, more widespread disease across both lobes where something like this may be a little bit more applicable. But you're right. I mean, I think trial setting and hopefully we can rely on some of that data that has been brought up and we'll figure it out as we go forward. Altan, you also have some specific experience with cutaneous melanoma, correct?
Right. So, our center, like I said, has been doing this for over a decade. So sarcomas, cutaneous melanomas are areas where we've explored this in the past. And the response rates, have been pretty reasonable. I think the challenges there are cutaneous melanoma is one of these things. There's a huge disparity between the progress that's been made in cutaneous melanoma versus uveal melanoma. Immunotherapy has revolutionized the treatment for cutaneous melanoma. Dacarbazine was FDA approved, over 3 or 4 decades ago, but that same milestone wasn't reached until we had tebentafusp, and that was in 2022. So it's just been a blank slate for uveal melanoma. So I think there's a little bit of a challenge in having this fit in other places. This would be kind of more of a salvage. I see it working in that setting.
Got it. Okay. That's super helpful as well. All right, gentlemen, I think our time is up. Any final thoughts? Any final words?
No, that's it. I mean, I think it's great that we have another promising therapy. To keep in mind, it's new. We have, I would say, more questions than answers right now, which is a little bit daunting, but also a little bit exciting as well.
And absolutely, a very exciting time for sure. I think collaborating across disciplines, medical oncology, surgical oncology, there's a real opportunity here to make some good differences for a lot of patients here.
Absolutely. Great points. Well, thank you to our listeners. Thank you to you both. Fantastic information, great dialogue. Appreciate both of you being on here today, this early morning on a Sunday. And we'll catch up soon.
Thanks, Kavi.
Take care.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dawn,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew
and Judy Dela Cruz.
Thanks again for listening.